these are the different terminologies which are used like osteogenesis, osteoinduction and osteoconduction. Osteogenesis is the formation of bone by cells contained in the graft material, whereas osteoinduction is the molecules in the graft, that is bone morphogenic proteins. They convert the neighboring cells into osteoblasts and induces the bone formation, so that we want to achieve. Whereas osteoconduction is the graft from the scaffolding from the outside cell to penetrate and form the new bone. They are classified as autograft. They can be from intraoral sites like osseous coagulum, bone blend, cancellous bone marrow or bone swallowing. Whereas extraoral sites, we have iliac crest bone, but which is not commonly used. Allografts are like DFDBA and FDBA are available in the market. Then xenografts like calf bone and the keel bone from the animal side can be used. Alloplasts are natural or synthetic. So synthetic are the plaster of Paris, HTR material, the calcium phosphated materials, bioactive glass and the coral derived material. These are again available in the market. So we'll just go one in detail. So first thing is the osseous coagulum. Basically it is a mixture of dust, bone dust and the bone. Along with the small particles of the cortical bone which you can obtain from exostosis or the edentulous reach, and then you have to mix it and pack it into the defect. Whereas the bone blend is again the same thing, but where here we have to have the autoclave plastic capsule and pestle which has to be triturated, and then you can get a plastic workable mass so which you can pack it into the defect. Intraoral cancellous bone marrow, which can be you can obtain it from the, when you reflect the flap, you can see that bone is there. You can remove it, remove the cortical bone and harvest the cancellous bone by using the rongeurs, curates or the trephines, and then you can get this and you can again pack it into the defect. Whereas bone swatching, again routinely asked for viva. Basically here the defect is there adjacent to the edentulous area, and here the bone has to be very elastic, so that with the chisel and the mallet you you push the bone into the defect. So care is taken not to fracture the base, and the bone has to be carefully pushed into the defect. The iliac crest graft, they are commonly used by orthopedic surgeons, not by periodontists, and done in the hospitals. The drawbacks of it is that it can cause a post-operative infection, chances of exfoliation and sequestration of graft. There is a varied rates of healing, root resorption, recurrence of the defect, and additional surgery is required. The allografts, basically they are the materials obtained from the another individual of same species. So you can take it from the cadaver, store in the bone banks, and has to be processed. The FDBA, that is undecalcified freeze-dried bone graft, they are osteoconductive material, whereas DFDBA, they are osteoinductive material. Because of the decalcification, it exposes the components of bone matrix. So these are available in different sizes, shapes. The xenografts, they are material obtained from the another species, so from the animal origin basically, so from the calf bone, keel bone or the ox bone. And the alloplasts, they are the non-bone graft material, non-bone material. The source can be natural and commercial. They have an osteoconductive property, and certain materials have been used and discarded like sclera, cartilage, plaster of Paris, but yes, there are some new synthetic materials which are available in the market. So these are the commercially available materials. The plastic material like HTR polymer, they are biocompatible, they are microporous, non-resorbable, like polymethyl methacrylate, polyhydroxylethyl methacrylate, calcium phosphate biomaterial, which has got the excellent biocompatibility, no antigenicity like hydroxyapatite, tricalcium phosphate. These are available and certain studies have been done on that. Then bioactive glass like sodium, calcium slots have been used and they have been coated with hydroxyapatite crystal. Then the coral derived are natural and they are also coral derived porous hydroxyapatite materials. So again the question is asked, what is the bone graft, classify and give combined technique. So it comes as a long answer question. So what are the silent features of that? Basically it is a regenerative type of the flap design you have to do for the elimination of epithelium. At the same time you are achieving the root biomodification by citric acid. You also want to prevent the epithelial migration and allow the certain cells from the periodontal ligament to regenerate. So you are using the GTR membrane. At the same time you want the regeneration, so you are using the DFDBA graft, which is an osteoinductive material. So these are few pictures by which you can see that defect is debrided, then graft is placed, it is covered, sutured, and then you can see the difference in the radiograph. So coming on to the periodontal plastics and aesthetic surgery, this is at such a big topic, but I will just try to enlighten. Basically, it is done to solve the problems related to the attached gingiva, like to widen the attached gingiva or to cover the denudated roots. Then in case of shallow vestibule, so you can deepen the vestibule, or if there is an aberrant frenum, so you can either relocate or you can completely remove. So they are pocket extending to mucogingival junction. So thick keratinized gingiva, if it is there, you can go for apically displaced flap. If there is a thin friable gingiva, you can go by the vestibular extension by doing a free gingival graft and connective tissue graft. Whereas there is the absence of attached gingiva, no pockets, but there is a progressive recession and inflammation, you will go for the vestibular extension, which can be achieved by free gingival graft, fenestration procedure, and enlargement operation. The root coverage can be achieved whenever there is adequate attached gingiva on the adjacent tooth. You can go for laterally displaced flap. Whenever there is an adequate attached gingiva apical to the recession, you can go for the coronary displaced flap, the Tarnows technique. And whenever there is a multiple recession without the papillary restriction, you can go for the tunnel and pouch technique. Inadequate attached gingiva, you can go for the free autografts by Miller's technique or the Langer technique. So these are the few individual techniques where you are going to go. Whenever there is a high frenum, either you can go for the frenectomy when there is a frenum which is causing the diastema, or there is a positive tension, you can just go for the frenotomy. It's just a relocating of the frenum. The absence of attached gingiva, no pockets, health is maintained, then you need not go for the surgery. So how do you classify recession? The Sullivan and Atkins has given the classification like shallow narrow, shallow wide, deep narrow, deep wide, and Miller has further classified as class 1. So where the marginal tissue recession is going beyond the mucogingival junction, it can be narrow or wide. At the same time, it has to be shallow, and no interdental soft tissue or the bone loss. Whereas in class 2, this marginal tissue recession is extending beyond the mucogingival junction, no interdental soft tissue or bone loss, and can be narrow or wide. The Miller's class 3 is the marginal tissue recession going beyond the mucogingival junction, where there is interdental soft tissue and bone loss or the tooth malpositioning will be there. Whereas in grade 4, this will be aggravated, so there will be severe interdental bone loss and the tooth loss and the tooth malpositioning will be there. So these are the certain techniques which are done along with the extension of the mucogingival surgery, that is the pre-prosthetic surgery, crown cleansing, ridge augmentation, papilla preservation, and the aesthetic surgical correction.